the Northlake group. So they've had to put up with me most of the semester. So welcome to class. So we're going to finish up the intracranial content from the pediatric perspective. Did want to go through some meningitis. I don't know how much meningitis we've done. So this is your PowerPoint that's available on your course. So we don't need to go through every slide, but this is an inflammatory condition. It can be caused by a bacterial infection. It involves the brain and spinal cord, viral or bacterial, or it can also be fungal. As we look at those, we focus primarily on the viral and bacterial. Those general clinical manifestations for both of them are headache, fever, photophobia, stiff neck, are also called nuchal rigidity. They can have seizures because of the irritation of the brain. Excuse me. These are some of our diagnostic treatments. So that lumbar puncture, they're talking about in your textbook to, if we are suspicious and wanting to do a lumbar puncture, to do an MRI or a CAT scan to make sure there's no shift in the brain matter. So when we do the lumbar puncture, we do not have a brainstem herniation. If the pressure is so high, it can actually cause herniation. So that may be something we do pre-procedure. For that lumbar puncture. Treatment is going to be antibiotics until we know that it's viral. Once we have identified it as viral, then those antibiotics would be stopped. We need to manage whatever those symptoms are, and generally it is self-limiting. The viral will run its course. They are less sick with a viral infection, a slower onset, where bacterial is a more sudden, rapid onset, and they are usually much sicker. So looking at bacterial meningitis, usually Staphylococcus or Neisseria meningitis. The elderly or debilitated are, again, those patients that are more at risk, and also people living in institutions or dormitories, and why, as you're going off to college, that were most of the colleges, and we requested for your meningitis immunization to be updated or boosted, okay? Because you are especially living in those dorms, okay? Let me back up. Also, some other risk factors for bacterial meningitis is tobacco use. For viral, can be a viral upper respiratory infection because both of these increase droplet formation. There's also increased risk of meningitis for people that have otitis media or mastoiditis because that's in the head and it's a direct communication to the brain area. And as we always find, those patients that have a decreased immune system would be at higher risk. It is that inflammatory process, and the outcome really depends on the infecting organism and the severity of the infection and the time from onset until treatment. The quicker we can intervene, the better outcomes, okay? Clinically, you're going to see some, come on. Fever, headache, that nuchal rigidity, photophobia. What is photophobia?
Aversion to light.
Yeah, light sensitivity. Decreased in level of consciousness. We can see signs of increased intracranial pressure, may have seizures. Some patients, if they have meningococcus meningitis, they may develop a rash. That even goes on to purpura, which are the big purple blotches on their skin. can have cranial nerve dysfunction, a positive Berdinsky sign. And what is the Berdinsky sign?
I don't remember which is which, but one of them is like you flex the neck and then the hip flexes too, and then the other one is the leg won't extend.
Okay, so the Berdinsky sign is when the neck is flexed, they flex their hips and their knees. Okay, also if we flex one leg, the other one will respond as well. The Berdinsky sign is more sensitive to meningitis than the Kernig sign. The Kernig sign is when we do neck flexion, they pull up their knees and hips. Okay, and you can see this. I don't know if we've got a picture. This is just a blank slide. The pictures are on figure 69.1 in your textbook to see those particular signs. Yes, Jessica.
Okay, so you said that the Berdinsky sign was the involuntary bending of the knees and the hips caused by the chin moving towards the chest. What is the Kernig sign?
The Kernig sign is when the thigh is flexed onto their abdomen. Okay, they cannot straighten the other leg, so you can't straighten that leg out. So once they flex those legs, you can't just straighten your knee. Okay.
Thank you. How would nursing interventions differ while providing care for a neonate versus a child, and then that elderly person versus an adult? Oops. Anybody? Well, a neonate isn't able to speak for themselves, so we might have to look for cues other than them verbally telling us that their head hurts, or I guess.
Excellent. So we are looking at those developmental differences, and how are we going to evaluate and identify, what's going on with our different age ranges because of their ability to communicate. Good. Anything as far as the elderly person versus a middle-aged adult? Again, could our older person be somewhat cognitively impaired and not be able to communicate as well? And are they going to always run a temperature as an adult would? Remember, their thermal regulation is a little off. Their hypothalamus has kind of reset and they have lower temperatures sometimes. When we're looking at the older adult in a possible UTI or sepsis, many times their temperature is low, so we can't rely on those elevated temperatures always. Excuse me. And again, looking at some objective data to identify what's going on with our patients to decide which interventions we need to be doing. So these are some age-related indications or signs of increased intracranial pressure. So the older adult might just have some additional confusion that that adult may not have. Our neonates really, as you said earlier, can't really identify things. So we're looking at feeding. We've talked about this in pediatrics earlier in the semester and last semester, that for our infants, one of the few things that we can consistently see is that they are not feeding well. When they are sick, they usually don't feel well, or poor feeding. Change in level of consciousness is also a big thing with infants. So they're not eating, their LOC is changing, and they are not interacting with us. So again, that listlessness, they could have some tenderness of their neck. The one thing, infants and children up to toddlers up to 18 months is that anterior fontanelle is not closed. At a 15, 16-month-old, it's getting very small, but it may still be open. It says, our textbooks say they close by 18 months. But our younger infants absolutely have this anterior fontanelle, so that is going to be bulging. It is tense. It is not pulsing, so this is a great big indication of their intracranial pressure. So it is increased and hydration. So it's increased intracranial pressure, that fontanelle is really going to be bulging. When they are quiet and not crying, remember that fontanelle is always going to bulge when they're crying, because what happens when you cry is your intracranial pressure goes up. So it will bulge up while they're crying, but it's not going to be that really hard tense. You can still have some palpation. It's softer. Although it's bulging, it's still soft. Poor cry, also a high-pitched cry, is very frequent with infants that have increased intracranial pressure and meningitis and muscle flaccicity. They're floppy. Whereas our kids, we get out of that, those preschoolers and kids, again, behavioral changes, arching of their back and neck, blank stare, again, refusal to eat, and seizures. My screen is freezing up. Y'all still there?
Yeah. Yes.
Yeah.
Okay. I want to make sure I hadn't lost you because my thing is not moving on.
Yeah.
So the next slide that would be coming up is those diagnostics. So we've already talked about the LP, so cerebral fluid evaluation. It finally closed out for me. Complete blood count. What do you expect the CBC to be showing?
High white blood cells.
Yeah, high white blood cells. MRI and CT scan, we already mentioned, to identify if there's any brain shifting before we do that LP. And we also want blood cultures, okay, to see what else is going on. Get a complete history, neurological status as we're doing our independent interventions. Check the cranial nerves, vital signs. Watch for any complications, especially respiratory or skin, as they may have that rash. They start getting compromised respiratorily. Why do we have respiratory compromise with a brain infection?
Pressure on the brainstem.
Right, can have some pressure on the brainstem, and the brain runs our respiratory center, right? So as that brain is getting irritated, we're getting that increased pressure. It's going to be causing that pressure and involving respiratory status. Collaborative interventions are, let me see if I can get this thing to come up again. What is collaborative interventions?
That's like what you do with the help of the doctor or the speech therapist or the physical therapist.
Yeah, the teamwork. So those things that we do, and they can be our independent actions as well as those collaborative things. So what are our collaborative actions?
Administering medication.
Okay, meds administration. What are we specifically wanting to do? What are some classifications of medications we might be giving?
Antibiotics.
Okay, antibiotics. Somebody else? Another one? Corticosteroids. Why are we giving corticosteroids?
To help with the inflammation.
Okay, so decrease that inflammation. Is there any particular time the corticosteroids should be given?
Yes, they should be given before the first dose of antibiotics, usually 15 to 20
Excellent.
minutes before.
So we want to get it in before the first dose and then every 6 hours for 4 days. The corticosteroid of choice per your book is going to be what?
Dexamethasone.
Yes, dexamethasone. Excellent. What is the preferred anti-infective or antibiotic?
Penicillin G.
Pinjib. Why?
Spectrum?
Pardon?
Is it because it's broad?
Say it again.
Is it because it's broad spectrum?
Broad spectrum, and we also need something that's going to cross the blood-brain barrier. We usually need to do it in conjunction with a cephalosporin. So we do double antibiotics. Okay, excellent. What else are we wanting to do? Somebody said analgesics. Why are we giving analgesics?
For the rigidity of the neck to help with the pain.
Yeah, they have a lot of pain, headache, stiff neck, all of those things going on. What is a medication that we can use to decrease cerebral edema?
Mannitol?
Absolutely. So mannitol is going to be important to help decrease that cerebral edema, along with the dexamethasone to decrease that cerebral edema and inflammation and irritation. What else do we want to do that's not medication related?
We want to decrease noxious stimuli to help decrease the ICP.
Okay. Decrease ICP, decrease risk of seizure. So how do we decrease that stimuli? Somebody else. What do we want to
keep the neck straight?
Keep the neck straight. Okay. Quiet. Absolutely. So keep it. We want a quiet room. They have photophobia. So what do we want to do with the lighting?
Dim lights.
Yeah, dim lights.
Darken the room.
Pardon? Say that again.
Oh, I just said darken the room.
Yeah, darken that room. Do we want mom and dad watching the football game to keep themselves entertained? I haven't shared the screen yet. I was having the conversation, then we'll pop up that slide. Yeah, we need to be aware of sound and, the TV and noise and things. We might want to close that room. Yeah, limit visitors to 1 or 2 at a time. Is it important to have visitors?
Yes, it is important.
We want to have those visitors, especially with our children. It can keep them calm, but it can also keep our adults calm. If they're confused, they're in and out of sleep or whatever, it can decrease their anxiety and stress when somebody familiar is there. Okay. What do we need to do room-wise and precautions that we need to have the families taking as we're going in and out of that room? This is an infectious disease, correct?
Wash
Hand
out.
washing always. Universal precautions always for every patient, no matter what their diagnosis. Are these patients on droplet precautions? Yeah, mask, absolutely. So they do need to be in isolation. And how long do they need to be in isolation?
Is it 24 hours after the initiation of antibiotics?
Absolutely correct. 24 hours after the start of antibiotics. So they've gotten those antibiotics on board. They are now considered non-infectious and we can stop our isolation. Or we put them in isolation and the diagnosis comes back that it is viral meningitis. Do they have to be in isolation for viral meningitis?
Yes.
Nope.
No.
So once they've had 24 hours of antibiotics for bacterial or it's been ruled viral, then they can come out of isolation. So here are those collaborative interventions. Let's not forget fluids, fluid maintenance. We've already talked about the antipyretic. So why are we isolating for COVID? Because COVID is droplet and viral meningitis is not a droplet. Yes, COVID is viral, but the identified spread is by droplet. And viral meningitis is not considered a droplet transmission. let me back up to our collaborative. This thing's getting crazy on me again, students. My thing is not working. They are not splitting CSS. What was that, Donnell? They're not splitting CSF. Okay. Oh, my darn thing is frozen up on me again. So those independent interventions, again, INO complications, we did that already. Our next thing would be, I was talking about fluid, so we want to maintain their fluid balance. We don't want to overhydrate them because we don't want to have any additional increased intracranial pressure. We already talked about minimizing stimulation and balance our activities. So remember, we've talked about cluster care in the past, that we go in and get things done so then we can give them periods of rest. But be aware if they seem to be getting more irritated, irritable, especially with our kids, to give them time between to rest. Let's see. Kind of lost here. Where are you lost, Elsa?
I was just trying to take notes. PowerPoint kept going back and forth, so I just stopped because I was getting.
Yeah, it's better to do your PowerPoints if you have them printed out. And I apologize that it's kind of going back and forth and it's freezing up for me. I can't, it's not letting me go forward. So I keep having to kind of click out of them.
Okay.
If y'all want to go over and pull up the PowerPoints yourself, and then you can just follow along and listen, that may work for you as well.
Okay.
Teaching, again, precautions. What is our biggest precaution or prevention for meningitis?
The vaccine?
Vaccines, exactly. So we've looked at most of the things for that's on the PowerPoint, except some of the case studies. And I have some questions that'll help with the case studies. And we're already at almost 9 o'clock. So I needed to go on and look at, oh my goodness, things are just bouncing around here. Okay. And it may be that our internet is running a little slow because there's so many of us. I'm going to switch over. Any questions on meningitis? Meningitis is very similar in adults, so it is adult as well as the pediatric.
Ms. Smith, which one is the most common out of all of the meningitis? Is it viral, bacterial, fungal?
The bacterial. Bacterial is the most frequent.
Okay.
And the most common cause is the Neisseria meningitis, and then followed up by pneumonia. Let me pronounce this correctly.
I had a question, Ms. Smith,
Mm-hmm.
on the type of isolation. Is it
Pardon?
droplet? The
Yes,
type
it's
of
droplet.
isolation?
Yes, droplet isolation. So droplet precautions.
Ms. Smith, I have a question.
Okay.
Why is it that, because I've always been exempt from getting the meningitis vaccine because of my age.
Right.
Why is that if adults can also get it?
I'm not sure, and I'm exempt as well. They do some of those exemptions, and not really sure why they do them. Probably thinking we're not going to be in those dormitories and things. But I don't have an answer for you. Michael, you had a question?
Yes, ma'am. My question, kind of off topic in regards to meningitis, though. because I was doing your case study last night, so I was a little confused about something. Is
On the hydrocephalus case study?
Yes, ma'am. So in hydrocephalus,
Okay.
is the CSF like increased production of it? Is that what's causing?
Okay,
Or
we're going to
is it
go in
mineral
and
water?
look at the hydrocephalus here in just a moment, Michael. Let me look through your comments
Okay.
here. Yes.
Miss Smith,
Yes.
I wanted to clarify just really quickly on the positioning of the patient. I have read in various textbooks and stuff that you elevate the head of the bed, and some say that you lay them flat with slightly elevated.
For
head
which
of
problem?
for meningitis. Usually, like because of the neck.
Uh,
I don't.
Okay. So what do the rest of y'all think?
There's so
15
many
to 30 degrees, 30 to 45. And for the neck, it's like, right. So we can elevate the head of the bed. Why do we elevate the head of the bed? What's going on with meningitis? Can it cause increased intracranial pressure? And what are those interventions to decrease intracranial pressure? So one of those is to elevate the head of the bed. Will help decrease intracranial pressure. We want to not have them coughing. We don't do a lot of suctioning because that increases pressure. So we're thinking about what is going to help decrease that intracranial pressure. The nuchal rigidity or the pain in their neck is when their neck is actually flexed. And I don't know if you guys can see me. So we're putting that chin toward their chest. So that's what causes the pain, and their neck needs to flex and things. Sometimes they have so much nuchal rigidity when you try to flex their neck, their whole body will raise up off the bed. So elevating the head of their bed is moving them from the waist, right, from their hips rather, and sitting them up. It's not flexing their neck. Pillow-wise, because of that neck rigidity, nuchal rigidity, and discomfort, I would use a very small flat pillow or maybe a small towel just at their neck area, like here, to keep that head in a neutral position rather than those big fat pillows. Everybody think about our pillows a lot of times in the hospital, pushes their head forward. So if we're doing that and we elevate the head of their bed, that is going to put a lot of flexion on their neck and increase their discomfort and irritability. So think about keeping that head and neck in that neutral position, that it's in alignment with their spine and not having that big flexing. Okay. Does that, excuse me, kind of answer your question?
Yes, it did. Thank you.
Okay, excellent. So let's quickly go over here and look at our slides on hydrocephalus. There's a lot of information in these slides on hydrocephalus that it does have a recording in connection with it. So I don't know how well this is going to play for us. I'm going to not play the recording. And are you going to, may not even, there we go. So on here, oh, that's a glare on there. I apologize. So here's some, again, some clinical manifestations of increased intracranial pressure for the infants. So again, that high-pitched cry, fontanelles, cranial sutures can be open. This Maywin sign, that's when you do a percussion on their head. It sounds like a jar or a pot that has a ceramic pot that has cracks. So it has this really hollow sound to it. One of the big things with infants and increasing intracranial pressure is their head measurement, the occipital frontal circumference, or measuring their head like we did when they were newborns, increases. So we have parents, when they have hydrocephalus, measuring that head on a daily basis, and that's what we do in the nursing as well. So as you go through these, we do have the differences. We're going to skip by those questions right now. Goodness, that glare when I was looking at this, not on this format, I didn't have that glare in there. I apologize. So light signs, you do need to be aware of these, is now we have bradycardia, decreasing LOC, decreasing motor response and sensory response, alteration in pupil size and reactivity, papilledema, which at our level, we're not going to see. This is when we do the otoscope, the ophthalmoscope, and we're looking in the eyes and we can see edema in the vessels of the retina. Flexion or extension posturing, that's decrepit and decerebrate posturing or Cheyne-Stokes respirations. And this is bouncing around again on us. I wanted to kind of get down to our hydrocephalus part. You all can read through here. At the end of this is also end of, or grief and end of life, and we'll talk about that next week. Assessment, again, sorry, my dog is yawning. Level of consciousness, pupillary response, vital signs. We may be doing these assessments every 15 minutes to 2 hours, depending on the how critical our child is. We're not going to look at our comatose. Yes, Michael.
Okay, I'm really trying. In the bed, is it 15 to 30 or 30 to 45? Because it's driving me crazy.
What I was trying to say is more for the level of comfort, but I will double check on that, Michael. And I'm writing myself a note. And I will get back and give you all a response by in your announcements. And is that comment? Yes, you do have PNC today. The North Lake group has already had PNC. And El Centro, I think you meet with Mr. Bobbitt at 11. At 12? Okay. Okay, so those comatose patients, we're going to kind of go on past that because this is more the intracranial pressure, generalized things. So we were doing that one. So I wanted to actually get to the hydrocephalus while we have some time. So this is imbalance of the cerebral spinal fluid. It can be communicating or non-communicating, or the non-obstructive or communicating is that everything is being produced and there's a problem with the not flowing out. The most common is this obstructive, that there's an obstruction between the third and fourth ventricle of the brain. So as it's being produced, it's not moving on. So that those ventricles of the brain are swelling. It may not be apparent at birth, and you can actually develop hydrocephalus as an adult or after birth from meningitis, can go on to hydrocephalus, as that debris can cause some obstruction. It could be caused by brain trauma that now causes a problem with the drainage and things. It may appear after the primary closure of a defect. So they have a problem and we correct it, and now we've created that hydrocephalus. And then it is a problem with distribution of the cerebral spinal fluid. Looking at this one, are you going to come up? Here's a picture of those ventricles. Okay, so what's going on? So these ventricles are increasing in size, and because it's the skull is closed, it causes pressure on the brain. With those newborns, though, because the sutures are not closed, their head will continue to increase in size, and they will get very, very large to the point they cannot that head can be almost as heavy as their body. So we want to monitor their head circumference, fontanelle tension, how firm is that fontanelle, and ultrasounds of the ventricle, how much is those ventricles of the brain increasing. The treatment is going to be primarily, the number one treatment is this ventricle peritoneal shunting. So we have to relieve the pressure on the brain. We've got to get rid of that extra fluid. So we put in a shunt. Oops, come back. Here's our little shunt. Dang, sorry, students. It's not cooperating with me. I guess I can't point very well. So at the top, you see the shunt in the ventricle. As you look down at that picture, there's a one-way valve. So as the pressure reaches a certain point, that valve opens and allows the cerebrospinal fluid to drain down. That shunt comes out and you can trace it down. It is under the skin. The question is, what is the normal size of the head? Depends on their age, and what we're looking at when we're doing those serial measurements is how fast is it increasing. Okay, so they should not be increasing 2 centimeters a day. Their head is growing too quickly. Okay, so the catheter is threaded underneath the skin, so you can follow that track down from their scalp, down through their neck, down their chest, and then it goes into the peritoneal cavity. So we're following that track. Is there any irritation? We do not do anything to that valve. It is a one-way pressure valve. It opens, it drains, and then when the pressure is down, it closes. I use CDC guidelines for the case study. Okay. So these are the things we're monitoring for. What are the primary complications of surgery or a VP shunt? Infection. Yes, what kind of infection are we looking at? Bacterial. Okay. So where are we concerned for this infection to occur?
At the shunt site?
At the shunt site. So spinal cord. Not typically the spinal cord, but yeah, the brain, more a meningitis because it is a direct into the brain. Where else might they get an infection?
The ventricles?
In the ventricles, at the valve, so that's still in the brain.
At
Abdominal
the
cavity,
peritoneal catheter?
yeah, and they get peritonitis because now we have this communication. They can also get an infection along the track where that has been tracked along underneath the skin. So we're assessing all of those areas. We do need to be monitoring for signs and symptoms of those potential infections or complications. So an actual physical exam, behavioral. Again, as the intracranial pressure increases, yes, blocked drain. So the valve can malfunction. So there are complications, primarily malfunction of the valve or an infection. So looking at those signs of increased intracranial pressure for a valve malfunction. If the valve is malfunctioning or there's a kink in the tubing along that tract that doesn't allow the fluid to drain, the child, adult, these people grow up to be adults. They still have these VP shunts. That hydrocephalus does not go away. So they're going to have multiple revisions as they grow. As we go back to this other, you have this placement in an infant. As they grow, is that catheter going to become too short to still be in the peritoneal cavity? So we have to have those revisions as that child grows. Then, so again, we're looking at, is it a malfunction of the shunt, the tubing, something's going on and we have increased pressure, or is it an infection? Their highest risk of infection is when?
Right after insertion of the catheters.
Right. Right, that first 1 to 2 months, they have a higher risk of infection, and then malfunction is that first year. They can go along swimmingly and not have any problems, but they can develop problems as we move along. Okay, so here's looking at all our things we want to be monitoring: variations from baseline, developmental issues. Is there a particular position this patient should be put in after surgery for a VP shunt? Flat, absolutely. Sideline, which side are they going to lie on? The non-affected side, so the non-operative side. It's not the affected, but where is that incision and where is that shunt? We don't want them laying with their head on that shunt. These are usually infants. Lost my thing there. These are infants, primarily newborns, so they're not going to be able to turn their head. So we do need to do some repositioning of their head, laying on their back. Remember, if they're sleeping, back to sleep. In the hospital, we can have them a little bit on their side because we're monitoring them constantly. Parents need to be told that these babies are going to be on their back to sleep and reposition that head, but not onto the operative side. If they have an external VP shunt, they should be flat because as we raise the head of their bed, that can drain more rapidly. So that external drainage device is if they've gotten an infected shunt and we have to let their infection clear up until they have a sterile cerebral spinal fluid. Okay, I wanted to quickly do your case study. We've got about 15 minutes here. I don't know if it's going to let me bring up this case study. We went through most of the slides for the meningitis, for the hydrocephalus. Y'all can always text me. The El Centro group, my phone number is 214-543-5683. Let me put that in. And I'll put that in the chat room. So 214-543-5683. Excellent. Thank you, Jessica. So if y'all need to text me and have some questions, just tell me your, 1538 and your name so I can get back to you. If I see a lot of questions, the same question from several of you, I'll try to put it up as an announcement or email those answers to you so that we can be on the same page. So here's our little scenario or a case study that we had. So we talked about the pathophysiology already for that. The ventricles make and absorb the cerebral spinal fluid, but it's not absorbed properly or not distributed properly. Excuse me. I think we just talked about the VP shunt and how that helps. Any questions about that?
No.
Okay, as we look at our case progression, what did y'all come up with as abnormal in this assessment? So is the baby's weight okay?
Yes.
Yes. So what are our neurological concerns?
Her head circumference was abnormal for her
Head
age.
circumference, okay.
It's difficult to console.
Mhm.
Difficult to console. What about her FOC?
It's increasing at a rapid rate, so
Excellent, okay. And Fontenelle? So you're looking at what is a deviation from normal. So that slightly bulging Fontenelle is not a normal finding, right?
Correct.
Okay. Should we be able to palpate the posterior fontanelle? This baby is 2 months old. Yeah, you should be.
Yes. Sorry.
Okay. Respiratorily, what is our concerns for the respiratory?
Her oxygen.
Brainstem?
Pardon?
Sorry, go ahead.
Just saying if the pressure affects the brainstem.
Okay, but looking at your assessment, is there anything out of normal on this respiratory assessment on this infant?
The rate?
No.
Yeah, the rate is too high. Okay, so that could be an indication of what? Pain, absolutely pain. Okay, and possibly increased intracranial pressure. Okay, so cardiovascularly, what's going on with your assessment?
Her heart rate is up.
Yeah, heart rate is up. So again,
Fever.
fever, discomfort. Is that temperature normal? Yeah. So we've got temperature and things are out of alignment. Let's see. And then we go on to blood pressure is okay, pulses are okay, GI. Are there any abnormalities or out of normal expected findings for GI?
The timing of her last feeding is
Right. So what is emesis an indication of? Excellent. So now the child is not eating for 6 hours and still having emesis. So that would be a real concern that they're having increased pressure. Okay. We've got our CT scan. Why are we doing all these? Why did we do that CT scan?
To make sure there's no shifting of the brain before you do an LP.
Okay. Right. Excellent. And when we did that LP, right. See those ventricles? Why are we doing the cell count culture, gram stain, glucose, and protein on the CSF?
Some of these tests are can specifically identify meningitis, like the glucose, protein.
Correct. Okay, and there's an excellent table in your MedSurg book showing what the results of the CSF for what the normal results are and what the expected findings for bacterial or viral meningitis would be. And if we're looking at a potential infection, we're going to, of this shunt, we're going to be looking for the same types of things. Okay. So got a few more questions for you. Where are we doing on our time? We're almost. So we did the EVD, the external ventricle drainage device. Thank you, table 61-1. Thank you very much. What position, so are we going to have this baby in, which is not one of your questions, but I'm asking you anyway. Are we going to elevate her, the head of her bed, or keep her flat? Flat, right, because this does not have that pressure valve. So we want to be very cautious. If we sit her up, we can quickly drain those ventricles and cause ventricular collapse and cause additional problems. Which medications are we not going to give in these medications that we have listed here?
Baclofen.
Baclofen, exactly. Is not that the dose is too high. Is baclofen indicated? What is baclofen, and is it indicated for?
It's a muscle relaxer.
Yeah, it's a muscle relaxant. So that's okay. So that is not an appropriate drug for this patient. What else? Anything else that would not be indicated for this patient?
Morphine, maybe?
Okay, morphine is for pain, so that would be appropriate. Yeah, the anapranil, which is what?
ACE inhibitor.
ACE inhibitor. And Jessica, what's your question? And it's an
I said no to
antihypertensive. So
sorry. I said no to morphine because I was reading a book, doesn't matter book, and it says that morphine may be contraindicated if there is, I guess, like increased intracranial pressure. So that's why I'm not sure if you would give it or not.
okay, but at this point, we've got her post-op. Should she have increased intracranial pressure when she has an EVD in? Okay, so that's a good catch, Jessica. But again, we want to relate it back to our patient. So now she should not be having, and morphine is good for pain control. Also slows those respirations. So we want to watch that respiration, but we do want to get her some pain control. And that's her only pain medication other than Tylenol, right? Tylenol is probably going to be given for her temperature and minimal pain. And if I just had some brain surgery, it'd be nice to have my baby comfortable. Okay. How can we also identify if this baby has some still increased pressure with an EVD in place? What is that that's there always on these newborns that adults and children don't have that we can assess? Fontanelles, can we check that fontanelle? So that the fontanelles, and that should be flat at this point. If that new device is working. So again, we have a really nice assessment data that we can look at for that increased intracranial pressure. Y'all did really well on this. Do you want the answer sheet sent to you? Yes, yes, yes. I knew that was going to be the answer. I will put it in the course with the blank one that I sent you, so I will make that available later on today. I wanted to quickly go on to another quick before Miss Hudson kicks me out. Have some questions for you. So let's do some question and answers. Okay, do this for me. Okay, hopefully this isn't too big. So the nurse is caring for a 6-month-old diagnosed with hydrocephalus. What sign best indicates increased intracranial pressure? Yeah, number 2, excellent. And y'all can just type in the number rather than having to type in the answer. Excellent. Can y'all see this, the whole question? Or do I need to read it to you? Okay, excellent. So let's pop those answers up. Everybody, I take it, is answering one. My answers are not showing up here on my screen. Okay, next one. This is a little longer. It cuts off. What part is cutting off, Elsa? So let me read this one.
I zoomed in. That's my fault.
Number 4. You can try to make it smaller on your screen, but Elsa, were you able to see the rest of it?
Yes, it fixed itself.
Okay. So yeah, we want to bring this child in because this child has got a malfunctioning valve or something's going on and we don't want to take any time. We don't want her in the pediatrician's office. She needs to be seen right now. Excellent job. Okay. Yeah, it can be an infection. So we really don't know exactly what's going on, but there is a problem with her shunt and we need to get her seen. Oops. Okay, next one. Yep. Oh, it keeps scheduling back on me. Let me see where I'm at. That's the one we just did. So this is where we're at. Okay. Yep, number 4. I see a 4. And what is the rationale for doing 4 first?
Because you want to get what's going on in the blood right now before you start any changing of it, I guess.
Okay. And that we have the right antibiotics. Okay. Somebody had said number 2, start maintenance fluids. And the big key there is maintenance fluids. Okay. We're not going to get the cerebrospinal fluid, right? We're going to assist in the LP, but then it's our job to get those things labeled and get them to the lab. Do we have to wait for the results to come back before we start the antibiotics? No, because that's going to take a while, right? They can get the gram stain really quickly on the CSF, but we're not going to get those results in the next few minutes. So the crucial is that we get them obtained and get them down to the lab as quickly as possible. Then we're going to get our fluids started and IV started so we can give our antibiotics. But we're going to get the cultures, then start our antibiotics. If they already have a heparin lock or a saline lock, we could do the antibiotics through there. But with the IV, it's maintenance fluids. This child or person is not fluid depleted, not dehydrated. Broad spectrum antibiotic we were talking about would be, again, the PNG and some cephalosporins because they are better at crossing that blood-brain barrier. Is that the one we're on? I think this might be our last question. You guys are quick. Okay, so yes, everybody's putting in number 3 because we do want them in that private room, minimal stimulus. We prefer them not to be in these other semi-private rooms, even if they are roommates that have the same thing. Ideally, the best would be that private room with minimal stimulus. Yes. Cheeto.
Okay, so if the child is allergic to penicillin, what else could you give?
We can do a cephalosporin. They were talking about Rocephin and some others. So, they're always going to have some alternate effective antibiotics that they can use. But I don't know, question-wise, if Ms. Hudson would be that specific. But we're always checking for those allergies. Even if they don't have any listed allergies, we always want to watch for any indication that they're developing an allergy, any itching, difficulty breathing, any rashes or anything. So just because they are not allergic at this moment doesn't mean they will not develop an allergy as we keep exposing them or sensitizing their immune system.
Okay. Thank you.
Other questions for me? Okay. Can we have a break? Yes, I will ask Ms. Hudson to give you a 10-minute break. You guys have done great. Got through a lot of information. Like I said, you have my number now. Ms. Hudson has joined the session. Can they have a little 10-minute break, please, Ms. Hudson? They've been working hard.
Yep, they can do that.
So you'll be back at 9:40. I enjoyed visiting with you. Let me know if you have any questions, and have a good rest of your morning. Thanks, group.
All right, so it's 9:40, or actually 9:41. How's everybody doing? Almost done for the morning. At least the majority of you are. All right, so I put in the chat. Check your email. So that because I sent you a meningitis case study. So we're going to break up into groups for the first few minutes. So we have 4 groups, and 2 groups will work on one case study, and the other 2 groups will work on another case study. So does everyone also have their Parkinson's case study that was sent out last week? Okay. All right. So this is what we're going to do. If you are in group 1 and 2, you're going to work on the meningitis case study that I just sent out. There's 11 questions. So group 1 will do questions 1 through 5. Group 2 will do questions 6 through 11. So that's your assignment. I did put the group. Whoops. Let me do that again. Group 2. Try that again. All right. So divide and conquer when you're in the group, and I will be checking between the groups. You'll know in just a minute. So just hang on. For the Parkinson's one that I sent out last week, let me just verify the number of questions. And it's going to be the Word document one. The one that's Elsie is 78 years old. So there's 10 questions there. So that's an easy count. So group 3 and 4 will work on Parkinson's. Group 3 would do questions 1 through 5. And group 6, listen to me, group 6. Group 4 would do questions 6 through 10. All right, so that's your assignment. So at 10:05, we will, let's see, we'll say 10:15. I'll give you 30 minutes. You'll probably be done by then. So we'll meet back at 10:15, and then we're going to present those. So hopefully everybody's in the group, because once I release the groups, and it's randomly assigned, so I didn't pick any, the computer's choosing who goes into what group. So once I say activate, then those breakout groups will begin, and once if you're not in it, you can't get in it. Does that make sense? So I have 51 people right now, so I'm hoping that everyone that should be in the group is in the group. Do we know of anyone that's struggling to get online and they're attempting to work that through? All right, so Diana just rejoined. Perfect. So let's see. All right, so here we go. We're gonna have 2 groups of 13. All right, so you back on? Okay, hold on. But you can see the assignment, correct, Elsa? All right. Perfect. And we're starting now. So how's it going in this group?
Ms. Hudson,
Yes.
I'm really confused. Sorry, I got into the chat a little bit late. So I am in group 1 and I'm doing questions 1 to 5. Is that correct?
No, you guys are, the group 1 altogether is doing questions 1 through 5. So you all should divide up who's going to work on it. So I'm checking in to see, you know, how you guys are dividing the work. So you shouldn't be individually doing it. You should be discussing it.
Got it. Thank you.
Okay, you're welcome. So that's why I was checking in to see where you guys were, how far along you got, how did you divide the work? It's 12 of you in this group, so there's 5 questions. You should be able to work through it without using the chat. You should be talking to each other so that way you can get through it quicker instead of using the chat to text.
Okay, thank you.
Sounds good.
Yep.
I don't think so. It's more the fact she's like a college student in tight quarters that would probably increase her risk factors. Also, in the book, it says there's recurrent infections, might be another one.
That's what I was thinking too, the recurrent sinus infections.
Thomas should, but we are doing the risk factors, right?
What up on the glucose level? Because it's 20. Is it not too low?
What about the white blood cells?
On the table 69-1 for the cerebral spinal fluid, it says glucose is supposed to be 45 to 80.
Yeah, so it's low.
Does anyone know what the level for protein is?
According to that table, it looks like if the glucose was less than 40, that it's supposed to be viral meningitis, or less than 45. It looks like it's indicative of 45 of viral meningitis. But I'm not sure if I'm reading that right. That sign is a greater than sign, so the less than 40 would probably be the bacterial meningitis.
Yeah, it's bacterial.
So you said less than 40 was bacterial?
For the glucose, yeah. And then the protein is supposed to be between 18 and 45. Since it's elevated over 500, that's indicative of bacterial as well for the protein.
So for the additional assessment data, I was thinking maybe like neuro checks, including like pupils, any reflexes.
And you can even ask if he was in any contact with anybody with meningitis.
We also don't have the culture and sensitivity back yet, right? I don't know if they even got that. To be able to determine what antibiotic we need to give later on, but that's just a broad spectrum.
Mm-hmm.
And on the assessment data, you can even ask if he had a meningitis vaccination.
I guess the big question is number 5. How do we differentiate meningitis from encephalitis, you guys?
So encephalitis is an inflammation. So I think checking the white blood cell level would show that there's an infection, which will tell you it's meningitis.
Yeah. When you look at it, both of them are caused by inflammation.
Yeah.
Yeah, but meningitis is mostly an infection of the brain.
No, brain and spinal cord, and encephalitis is of the meninges.
So I guess looking at the result of the lumbar puncture.
Yes. And encephalitis can be transmitted through the bite of an infected mosquito or tick.
Encephalitis is transmitted.
Yeah, through the bite of an infected mosquito or tick.
Okay. How? What do the insects transmit?
It's transmitted
it's like you can get it through a bite, a mosquito bite, or a tick.
I think I'm trying to find it and pull it up, but I think another thing that makes it different is the encephalitis you'll see more seizures in that than meningitis, and then I don't think you'll see the neck stiffness with encephalitis. But I'm trying to find the where I read that.
Oh, okay, I get it now.
Okay.
So encephalitis it involves the brain itself, but meningitis doesn't get into the brain itself. It's just the meninges and the membranes that surround the brain and the spinal cord. So I think the lumbar puncture would, like Marisa said, the lumbar puncture would tell the difference.
I have another hour. Can you go away just for an hour?
All right. How's it going? Everybody good? All right. Any questions? If not, then we will check on the remaining groups. Are you guys done?
Yes.
I believe so.
Let me check on the other groups and see if they're done. You still have 7 minutes in case you need it.
We only had questions 1 through 5, right, guys?
Yes.
Yeah.
Hey, I'm reading in the book, and if I understand this right, I think for encephalitis, it seems as if the glucose would be normal within normal limits.
Oh, okay, thank you.
What book are you reading it from?
Hold on, I'll copy.
Okay. Yeah, I was on the Patho book, but there was like just 2 paragraphs. It didn't really go into detail about the like the diagnostic tests.
It's I just posted it in the chat. It's a long text. I found it in the Med Surg book when I was looking up encephalitis. It's more like the herpes simplex encephalitis, but it had a paragraph about assessment and diagnostic findings.
Thanks.
They're going to be showing up here. All right, so everybody should be all back in one room, correct? Is the gang all here? I think we still have 4 more reconnecting. All right. Perfect. So we'll start with groups 1 and 2. So group 1, you had questions 1 through 5, and then you ladies can also chime in as well because you work on the same case study for meningitis. So the first question here, let me share this real quick. I'm going to share my screen. So what you should be seeing is the case study. All right. So group 1, you had, these were all of the lab values, so everybody should have the same case study. We did an assessment on cranial nerve 11, pain to the neck. So, you know, when you're looking at the case study, let's just start with that. I would start with, and this would be the same thing if you were looking at any other question. What things are abnormal? So let's just go back. We have a 21-year-old person. Okay, we gotta go in front of it. There we go. And so now they come to the emergency room. They have a bad headache, nausea, vomiting, and neck tightening. And the person says, my sinuses are bothering me last week, but I thought I was getting better, not getting better. So they've had recent or recurrent sinus infections, no drug use, social drinker on the weekends. And so we have a little bit of a fever. Pulse is 104. Blood pressure looks pretty good. Although they're awake and alert, we have periods of confusion and agitation over the last 4 hours. And lungs are slightly diminished. So, you know, mucous membranes are dry, so they definitely look dehydrated. Cap refill is less than 3 seconds. Is that normal or abnormal?
It's normal.
Okay. So we have neck pain, unequal pupillary responses. Is that normal?
No.
Okay. So now we get to the LP, the lumbar puncture, which we're going to do the cerebral spinal fluid. Should it be turbid or clear?
Clear.
Okay. And should it normally have white cells in it? Yes or no?
No.
Okay. We also have glucose, which is at 20. So it's that's a low number. And then we have protein that's really high. Trying to go in front of it. There we go. So we have no obstructions or anything like that. Okay, so what should be normal ranges? What are normal ranges? And this is either group 1 or group 2 can answer this question. When you're looking at the cerebral spinal fluid. Because if there's an abnormality, you're going to be the person they're going to call with the results.
So the glucose should be 45 to 80.
So it should be higher.
Yes.
Okay. No, I'm agreeing with you. Go ahead.
And the protein should be 18 to 45.
Okay. What about the white cells?
0 to 5.
So the WB should be less than 5.
Yes.
Okay. All right, but it looks like we have 560 of those in there. Okay. All right. So meningitis. Define meningitis. What are the different types? Yes. What's your question?
Someone answered it. We were trying to figure out what the glucose range was. They said 45 to 80.
Yes. Okay. So what is meningitis? What are the different types and which one is common? So that should be our first question. All right, go guys. Group 1.
Okay, it's an inflammation of the meninges, which cover the brain and spinal cord. The three major types are the bacterial, viral, and fungal. Bacterial is the most common, usually streptococcus or Neisseria meningitis.
Okay. I think is there a question in there?
Yes. I read somewhere that bacterial is less common but more severe. So I just want to clarify that. Which one's more common?
Usually, bacterial is definitely the most deadly. But I do believe that I can't say they each have equal. I think viral meningitis is what most people get, is the most commonly one seen. If you get bacterial, then bacterial meningitis is usually that person's going to, symptoms happen pretty quickly, wherein viral symptoms happen over a week.
Okay.
So does that make sense?
Yes. So viral more common. Bacterial more serious. Okay.
But understand, depending on which body type we're talking about, adult, PD, or elderly, that number, those things may fluctuate. But that viral happens over time. Usually takes about a week for it to happen. And you have bacterial, which can be fatal. So that is especially within 24 hours. So you need to respond to bacterial. But these are the three most common types of meningitis. It's either a fungal meningitis, a viral meningitis, or bacterial meningitis. I think for me, the bigger focus would be, if it's viral, how am I going to treat it? What would I expect? If it's bacterial, I know that this is going to be significant because, X, Y, and Z. If this isn't a baby, this is going to be a game changer, and especially if it's a baby that is in the neonate stage, so within 30 days post-delivery. Does that make sense?
Yes.
Okay. All right. So I agree that the inflammation of the meninges would be, the subarachnoid space in the spinal fluid and encephalitis, because I think there was a question about that, is basically inflammation of the brain itself. So there are different types of viral, bacterial. HIV is H. influenza, which is the most causative agent for bacterial meningitis. And you have meningococcal meningitis, which is caused by the Neisseria meningitidis bacteria. Then you have pneumococcal meningitis, which is caused by the Streptococcus pneumoniae bacteria. So just understand that, we have viral, fungal, bacterial. And, bacterial is, the strep, the group B strep, the Neisseria meningitidis, the H. influenza. Your viral is going to be the enteroviruses. So, there's echovirus, there's herpes simplex virus, and HIV. And then your fungal is going to be your cryptococcal or your histoplasma capsulatum. So that's, that gets a little deep. So it's not that I don't want you to know it. I just want you to understand that, that you're primarily going to probably see most often is going to be either viral or bacterial. There was a question.
Yes, Ms. Hudson. Did you mention H influenza?
I did.
Or okay.
It's H influenza B. That's what HIV is right here. That was the first one.
Okay.
Okay. And then I came back and followed it up with that. Yes.
What were the fungal ones again?
Cryptococcus and Histoplasma capsulatum. But at the end of the day, just, understand there's a fungal, there's a bacterial, there's a viral. Let's kind of wrap our heads around that first. And then people that are more at risk for developing, which is the next question that we're getting ready to get to. Because what I don't want you to do is get so bogged down in this bacteria, that bacteria, this bacteria, but understand that H influenza is definitely one of the issues. Neisseria meningitis is definitely an issue. Streptococcus is definitely an issue. So if you want to hone in on those bacteria as being the common bacteria for bacterial, I don't have a problem with that. But the likelihood of you seeing a lot of fungal would be in your more immunocompromised folks. Does that make sense?
Okay.
Okay. All right, go ahead. Question 2. What are the risk factors? And this is for not just in general. What were her risk factors? Right. So she's in a crowded living situation, which is a dorm. She's 21, and it can, this can happen anywhere. Although I know Lippincott says it's normally seen in folks over 60, but we already know kiddos get those as well. So that also puts people folks at risk. Anything else? She didn't have any head trauma or anything of that nature. She had that recurrent sinus infection that she thought was going to resolve itself. So even in that crowded condition, she may be immunosuppressed. It's college, and how often do you sleep when you're in college?
Never.
Exactly. So that also weakens your body system. But, somehow it enters into the body system, and now we have an issue.
Can being a social drinker put her at risk too, or no?
Being a social drinker, it depends on what social means to her. So, patients or some folks will say, I only drink on the weekend socially, but they're taking out 3 cases of beer. I mean, to me, that's alcoholism. That's 72 cans or bottles or whatever it is. That's a lot of beer. So, depending on how much she's drinking, that could definitely play a role in putting her at risk. So for her, let me go back here so I can move the screen. All right. Did she get all of her vaccinations? We don't know. But we see that bacterial is more common in folks under 20. Her living in a community setting. There was no indication of pregnancy, but we did talk about a compromised immune system. She didn't have diabetes, so that wasn't one of the issues that we needed to be worried about. Clinical manifestations for you to note at this time. What did she complain of?
Headache.
She had a headache.
Stiff neck.
She had nuchal rigidity, which is a
nausea.
And then her last thing was her mental status, because remember, her mental status started changing. Although she was alert and oriented times 3, she still had a mental status issue, right?
Yeah, the confusion.
She looks funny. She looks like a boy. Wait, what?
I thought you said yesterday. You said
So does that make sense?
Yes.
Okay. So there was headache, neck stiffness, or nuchal rigidity, and alteration in mental status. And then it'll continue to decline as the situation gets worse. So, question of the day is what is that known as? Those three things, according to your book.
Brudzinski?
Those three things are known as bacterial meningitis triad. Neck stiffness, headache, and mental status changes. Okay. So does she not? She had all of those. Those three were her complaints. And then we also had vomiting. But the bacterial meningitis triad is what that is known as. All right, so what additional assessments should you get? Okay, so we could do a Brudzinski's, we could do that, and we could also do Koenig's sign. We could get that as well. Okay? Yep, Koenig's would be an additional one. All right.
Ms. Hudson, don't we all still need a culture and sensitivity to determine which antibiotic to start her on?
That is true.
Broad spectrum before it comes back, but
No, but you want to make sure that she's getting the right one.
right.
Does that make sense? So we will still start her broad, but we still need to get the right one, and we'll talk about that. So we need more background information, how long she's had these symptoms. She's been kind of vague to say she thought it was sinus, a neurologic status assessment, vital signs for decompensation. We would do additional lab work, so that we would do, blood cultures and things of that nature to make sure it's not in the blood. We will send off that CSF for culture as well, so that they can determine which antibiotic she's going to be placed on. So that would be the additional stuff that we would need to do for her. Okay. And we already got our info there. So diagnostic findings differentiate meningitis from encephalitis. Well, this would be the Brudzinski's and the Koenig sign. So what is the Brudzinski's sign?
When you flex the neck and the hip and knee flex too, right?
Yes, you get neck flexion results in the knee and the hip flexing at the same time. Koenig's sign is hamstring stiffness that results in an inability for the leg to be straightened when the hips is flexed to 90 degrees. So, again, these signs are things that are common on NCLEX to, help you identify, what your patient actually has, and especially for meningitis, these two would be perfect. What cases group 2 of classes of medication would be most likely prescribed for a client with acute bacterial meningitis, and identify 2 nursing complications for each?
The antibiotics.
Okay, so when we're giving these folks antibiotics, do they get better immediately?
No.
So they're actually going to get a little bit worse before they get better. And that's because of the bacteria trying to, the antibiotic to eliminate the bacteria, but the bacteria is also going to release endotoxins, which is going to create more trouble. Especially for kiddos, they may want to increase their volume status beforehand or have some blood pressure increaser medication, a vasoactive medication available just in case the kiddo's pressure does tank. So those are things that, you know, they want to have RRT on standby that you want to also initiate. Other things, allergies, that's going to be another thing you want to look at to, especially with antibiotics and, you know, in allergies, penicillin, you want to make sure that this person won't have an allergic reaction to that. Speaking about antibiotics, there's different types depending on, you know, which of these bacteria they need to fight. Overall, the penicillins is kind of where they start. So, but it's not uncommon for them to get a cephalosporin as an alternative treatment, a third generation cephalosporin. So they may actually receive that to help manage the situation. But for your more common bacterial meningitis cases, they're going to start them with some type of penicillin. If they're resistant to penicillin, then they may go to something much bigger. If they're resistant to penicillin, and they have other other antibiotics that they can give. So if penicillin doesn't work, they may use a cephalosporin. They may use a fluoroquinolone. So they have there's different types of antibiotics. And just for the record, cephalosporin has about 8 generations worth of antibiotics within itself. So you have a first generation cephalosporin, a 5th, 6th, and 7th, and 8th generation of cephalosporin. The higher the number of generations, the more potent that antibiotic should be in actually killing the bacteria that the patient may have. Okay. So other things, besides antibiotics, what else would they need? What other medications would we consider giving patients that have meningitis?
Corticosteroid.
They're gonna need a corticosteroid, so we would have to, what are our responsibilities for that? So how would that corticosteroid, you know, impact the patient?
Going to decrease their but also we need to watch for it's lowering their immune status.
Right. So their immune status is probably already weakened with the antibiotics. This is going to drop this because remember, antibiotics kill all bacteria, good and bad. And so now we're giving them something else that's immunosuppressant. So, you know, what type of isolation should they be on anyway?
Respiratory isolation.
Standard and droplet.
So droplet and contact isolation. So, you know, we want to make sure that we have our isolation protocols in order. Okay. And then look at some of these antibiotics to see if they're a nephrotoxin or if they are a hepatotoxin. So that way you're not giving it to patients and, you know, creating additional issues for them. So kind of the short of it is antibiotic therapy, look for allergies, assess for the type of organisms, and then you're going to look for any toxicities related for that. For your corticosteroids, then, you know, check blood pressures and weights and check their ABGs, respiratory status, stuff that we've already spoke about. All right, 7. So interventions pre and post lumbar puncture. And this is going to depend, like if this is a little baby or a kiddo, you want to make sure that you can visualize their ability to breathe. So don't, you know, when you're going to have the baby in the knee chest position, kind of with a back curved. So we don't want to not be able to see what their nose is doing, what their chest wall is doing. And we don't want to crunch them too tight that we end up creating a respiratory problem. That's, you know, that's one thing. We're going to look for fluid leakage, consistency, smell, monitor for signs and symptoms of infection, make sure the skin's been cleaned before the procedure, they use sterile technique, and then educate the patient to stay still for the procedure and minimize movement. Usually the babies, we just lay them back in the bed. Adults, we just give them the information, and then pain medication prior to the procedure if they're unable to tolerate it. All right, group 2, question 8. What will be your priority areas here?
We have like acute pain, ineffective tissue perfusion, cerebral, risk for injury and infection, as well as disturbed sensory perception.
Okay. So sensory perception for sure, related to the cerebral edema and increased ICP. So they already have an alteration in mental status, acute pain. Skin integrity, we can look at that as well. What other ones? Any others? Are we good there?
I'm just seeing if somebody else wants to add to it.
I didn't hear you, babe.
Oh, I was seeing if somebody else wants to add to it. Since we had a large group, I didn't know if somebody else wants to add.
Somebody said risk for infection, but doesn't she already have an infection?
Yeah, the patient already has an infection, but how about sepsis? Yeah.
Risk for sepsis.
Yeah, they can have, septic shock.
How about risk for like fluid and electrolyte imbalance?
True, they can. So, septic shock, because if it's bacterial, then that bacteria could be get in the blood. So it could be meningeal toxemia, and that's going to be a problem. So, if they have septic shock, then they can end up in organ failure. Okay. All right, nursing intervention. So ABCs, patent airway, neural status for the patient, vital signs, oxygenation, pain medication, your GCS, related to the LOC, checking pupils when they're talking about neurologic status, and what are their grip strengths and pedal pushes and so forth and so on. So that'll be that one. And how would you as the nurse evaluate effectiveness for your nursing interventions? So pain level decrease, symptoms subside by not having any headaches, lab results and cultures within normal limits, pupillary responses, no Brudinski's, no Koenig sign. So that's how you know that things are working. If you initiate interventions that were not effective, what additional interventions would you implement? Then, administer oxygen low flow, call your PCP if symptoms worsen for, updated orders, and then give antibiotics to decrease the infection if what's currently being given isn't working. So that's what you would do for that. All right, so let's look at, did we miss anything on education-wise? Because we're going to do range of motion exercises with them, the shock, the SCDs. Make sure we do good skin care. And there's other things. What if they develop a rash? Because, you talked about skin integrity, but no one actually talked about, in what respect. And then what rash would they develop?
Like a purpuric or petechial rash?
So the petechiae and the purpura. So petechiae has like little red pimples, and the purpura looks like red blotches, almost like bruises. let's see. Anything else could be a cause of meningitis. So we have the bacterial infection. What about head injuries, skull fractures? Medications could. We got our triad: nausea, vomiting, fever, photophobia, confusion. And then there's another one with nuchal rigidity, photophobia, and a headache, which is different than nuchal rigidity, alteration of mental status, and neck stiffness. So that's another sign, which is, let me just spell it out here. So that's nuchal rigidity, photophobia, so light sensitivity, and headache. But yeah, the two rashes are petechiae and purpura. What assessment on an infant would you see? And I'm saying an infant. So what other assessment tools could you see that would be an indicator of increased ICP? And this would have to do with the soft spot.
Bulging fontanelles.
Right. So remember, bulging fontanelles is indicative of increased intracranial pressure. So an increased intracranial pressure plus a fever is meningitis. So bulging fontanelle and plus a fever. Oops. Not pulse. That equals meningitis. If it's just the bulging fontanelle only, I'm just going to put BF only, then that's equal to just only ICP. If you have a bulging fontanelle plus a fever, then that's meningitis. And we're speaking of the anterior fontanelle, by the way, because the posterior closes 4 to 6 months, and your anterior doesn't usually close. The average month is 18 months. So you can use that all the way up until 18 months of age as a guiding sign to let you know that the patient may have meningitis. And the other thing, they could have a seizure. So all of those things coupled together. But they would have, white cells in their increased white cell count, blood cultures will be positive, and, get a chest x-ray, CT scan, lumbar puncture. Okay. All right, so let's look at Parkinson's disease. We'll look at that. All right, so this is LC. So here's LC. They have a 3-year history of Parkinson's disease. Retired engineer, married, lives with his wife, small community. So since his last visit to the clinic, he reports tremors are about the same. However, further question reveals that he feels his gait is perhaps a little more unsteady and fatigue is slightly more noticeable. So he's concerned about the increased drooling. Medications are carbidopa, levodopa, 4 times a day. Then we also have amantadine at breakfast. So on the previous visit, the carbidopa, levodopa was increased from 3 to 4 times a day. He reports that he's become more somnolent with his regimen and that his dyskinesia movements appear to be worse just after taking the medication. So, okay, guys, what's Parkinson's disease? Where's our deficit? Where's our issue?
We have a decreased level of dopamine. It's progressive neurological movement disorder, eventually leading to partial or total disability.
Okay, so you know, when you have the, so it's dopamine, so the neuron that's affected is the dopaminergic neuron, and it's degenerating, degrading, whichever term you want to use, but it becomes compromised. Eventually that neuron will die. And if in a normal person, then if the dopaminergic neuron would release dopamine to the next neuron, and that's how the impulse would continue through the neurotransmitter, which is dopamine, which would allow for movement. So dopamine and acetylcholine must be in balance. So if we have a lack of dopamine that's making it to the receptors on the other neuron, and we also have the neuron that's dying out, then we have an excess of acetylcholine, hence is the reason why the patient ends up with tremors, so forth and so on. But dopamine is responsible for our balance. And, you know, the balance is coming, that particular neuron that's servicing our balance, or the dopamine, is located in the midbrain. And our midbrain is responsible for, you know, our movements. So, you know, if, as I said before, if we are having dopamine deficiency, then this is going to be an issue because it's responsible for movement accuracy, which is the reason why if the individual doesn't have the dopamine, then their movements are not going to be accurate, and they're going to have all the other issues that are associated with it. So this is a chronic progressive neurodegenerative disorder. And so they do have bradykinesia, rigidity and muscle tone, tremors while at rest, trouble with gait, and trouble with their posture, balance, and coordination.
So
Sorry. Go ahead.
If dopamine, the dopamine neurons that use the dopamine are inhibitory more so because it balances out with acetylcholine, so it's like too much movement without the dopamine.
So yes, your dopamine is an inhibitory neurotransmitter. Your acetylcholine is an excitatory neurotransmitter. And so the acetylcholine is going to cause the cholinergic effects. So if you don't have dopamine, or if you have less available, then your cholinergic signs and symptoms or responses are what you're going to see primarily, which is the other reason why we give them anticholinergics, because if we give them that, then that suppresses that extra excitability. Does that make sense?
Yeah. So that's also like with the antipsychotics that they give for like schizophrenia and stuff that inhibits dopamine. That's why they can get side effects of like too much movement and like Parkinson's like kind of side effects, right?
Mm-hmm. Correct. So, you know, usually you see that overstimulation happening in your younger folks before you see it in your older people. It doesn't mean they don't get it, but if like Michael J. Fox, he had a lot of those symptoms very early, and it was very noticeable for him. But the medications will help slow down the activity of the cholinergic action. So that's kind of what that role is. But we'll talk about him having the drooling, him having the mask-like face, so expressionless is the word that they normally use. So what is Parkinsonism? It's a term used to describe the signs and symptoms that can be found, such as bradykinesia, rigidity, poor balance, and how the patients do not exhibit the tremors. They usually two side effects are affected almost equally. So they may not respond to the beta-dopa, levodopa, and deep brain stimulation doesn't work. What are the clinical manifestations? So place a star next to the signs and symptoms listed above. So here, you can break it down like this. These are the motor ones, which is quite a bit. So tremors, akinesia. What is akinesia? And what is significant about akinesia?
Doesn't that mean like difficulty moving around?
So brady means slow movements, and kinesia means movement. So this would be without movement. So it's where they get the freezing up that happens. So they actually freeze in place, losing their ability to, move the muscles because they can't move their muscles voluntarily. They can also have walking and gait difficulties, postural problems, because what they'll try to do to counterbalance is they'll bend over at the hip, and so they kind of have that forward bending. It's almost like they're walking humped over, but they're doing that to counterbalance the instability that they're actually feeling. So from a non-motor related problem, usually they have that loss of sense of smell and sleeping issues, fatigue, constipation, and depression. That would also be something we need to monitor the patients for, because this is a life-altering condition. So moving on to the next one. Additional weight loss, lightheadedness, urinary problems, sweating, melanomas. There's a laundry list. But our key findings will be tremors that happen at rest, and those tremors could be in the limbs, the arms and the legs, the jaw, the tongue, which is the reason why they have that mask-like face, and it also sets up for the drooling. They also have something called a cogwheel rigidity, so they have passive movements of the arms towards the body. So if you try to move their extremity closer to the body, then the patient's body, because of the lack of dopamine, is going to actually make it jerk back instead of just a smooth transition, like if you're doing adduction and abduction. And it's really slow, so that's why they have that jerky movement. Difficulty swallowing is going to be related to, can you mute yourself, please? Thank you. The difficulty swallowing is going to be related to the bradykinesia. So that's why they have the drooling, the expressionless face. All of that's because things are moving in slow motion. So it's almost as if it's not moving at all, which will set up the patient for, having not their inability to swallow or aspiration risk. Because if they can't swallow or manage their secretions, then that individual may actually end up with a foreign body airway obstruction, which is something we don't want to see happen. Usually those signs and symptoms start off kind of subtle, but get worse over time. It may affect one side of the body, but then progress throughout the entire body. The tremors do get better if the folks are moving, so exercise usually helps with that. Sometimes their body looks kind of like it's really stiff, like especially the arms. So if they're trying to walk, usually when you walk, your arms sway, their arms will just hang down to the side. So their coordination is definitely off. But safety is going to be a huge concern for these individuals because of their compensatory mechanisms to like stoop forward to try to counterbalance and making sure we don't create other issues for them. And then talk about how to make sure there's no clutter and things like that in the household. They have side rails to help them get around, a cane, maybe a four-prong cane, or a walker with the rubber tips to assist with that. How the doctor knows that the person really has the disease? They never did a lot of testing, so how is it diagnosed? So we're going to get patient history and clinical features. So if they see that pin rolling, which is basically tremors in the hands and the fingers, and so it's tremoring to the point that it almost looks like the patient actually has a pill in their hand and they're rolling it around. They're going to look for the presence or absence of symptoms to make sure they're diagnosing it correctly. A neurological exam, they may do an MRI, CT scan, but these are usually used when the diagnosis is uncertain for the diagnostic tools. So they ask, why don't they give the dopamine pill? Wouldn't that fix everything? Why is oral dopamine not a replacement therapy? So it's not effective because it can't cross the blood-brain barrier. There are also no transporters available within the body to help dopamine across the blood-brain barrier. So this is why they have the secondary mechanism. So why do they give the levodopa? in combination with the carbidopa. That's because carbidopa prevents levodopa from being broken down and in the body system before it can reach the brain. So levodopa is converted into dopamine once it's in the brain, and then it's utilized appropriately. So they take this, because he takes Setamet, what serious adverse effects would you assess for? And so one was, this would be suicidal thoughts. And why would when I was in one of the groups, someone said, why suicidal thoughts? They saw depression. But just think about if you are a young individual and you get diagnosed with this condition and how that's going to change your whole lifestyle, your ability to even put your clothes on. So even for that, they're recommending Velcro shoes or slip-on shoes, no button shirts, no zip shirts, like just sweatshirts. Basically, your life will be, elastic band pants. So whether you're a guy or a girl, this would definitely be a huge change, and just the ability to do the basic LDLs. So, they would probably get to suicidal thoughts because they're depressed about what their whole lifestyle would be like, even with the medication. Because is this curable? Does the medication cure the disease or help minimize the symptoms?
Minimizes symptoms.
Minimizes the symptoms.
It just minimizes the symptoms. There's no cure. Okay, whether it's a genetic, environmental, whatever the cause may be, there's no cure for it. Right? So here's the wife. They have a couple questions. Why can't they do some kind of surgery? How would you describe surgical treatments? So they're usually done on patients who are not responding to drug therapy. So you have that deep brain stimulation that they could do for the individual. And this just describe how that happens. But the device delivers specific current to the brain to help reduce the dyskinesia, to improve motor function, but it doesn't fix it. So it's basically doing the same thing that medications do, but just with stimulation. Ablation could be done, and that's where they locate and destroy the areas of the brain that's affected by Parkinson's disease. And, this usually is located right at the base of the cerebrum and right at the superior portion of the cerebellum. So they're very close together. And, cerebellum does work with gait, which is the reason why they have a lot of gait issues. They can do a fetal neural tissue transplant in the basal ganglia, and that can also help to improve or provide. Trying to remember what DA was when I wrote that. Hold on. I think it's dopaminergic cells, if I remember. All right, so LC is reporting that his gait is more unsteady. There's an increased risk of falls. So things you can do for him, yes, he has to consciously think about walking, lifting up his legs almost in a march-like formation to alleviate that shuffling gait that they also experience. There are some up-to-date or newer assistive devices that actually has a laser pointer. So when they get to that freezing point, then that laser will kind of guide them. They're actually, recommending for them to change positions to to kind of change their position so that way they don't fall. So if they're going straight, to kind of make one step over to the left or to the right. 3 nutritional interventions that can be done. Increase fiber, but you got to be careful with increasing or having a fiber-rich diet when they're taking the medications, because it will compete with the medications and decrease the absorption of the meds. So those fiber-rich should come when not at meal times, but increase fruits and vegetables. Drink more water to alleviate constipation. Also boost vitamins and minerals. They can do that. No caffeine or limit caffeine and alcoholism so that they stay hydrated and eliminate cramps. Dark leafy green vegetables, which are really high, that can help with the free radicals to help eliminate Parkinson's disease. But taking that medication with the that's high in fiber. So you don't want to do it at the medication time because it'll compete with the protein, and then we'll end up losing nutrients or losing the effectiveness of the medication. So I kind of addressed some of the other things for patient education about the shirts and things like that, so that they can maintain. We want to try to maintain their autonomy at all costs. Someone with a condition like this would actually be more isolated because they don't want anyone to notice that they have these deficits, which is the reason why those suicidal thoughts, because they just want to be over it, and they start reminiscing on what their life used to be before this happened to them. So support groups would be great, encouraging exercises, and also if the person is struggling, with walking, so forth and so on, inform the family or educate the family on not rushing them, because if you rush them, then they get that's going to increase their signs and symptoms worse. So it's going to stress them out. So just try not to stress the people out. So, any questions on Parkinson's disease? Yes.
Okay, so Ms. Hudson, if just to guess out here, so if a question on the test, said to avoid caffeine and alcohol consumption, would that be wrong, since technically we should just limit it and they can still have some? Or
if it asks you what are some of the teaching strategies, that you can implore the patient to do, telling somebody to quit alcohol altogether, I mean, that depending on how much they drink it, and they're probably going to drink more because now they're depressed. But if you encourage them to, avoid it, to eliminate, then that would be appropriate. Does that make sense? The less they do of it, the better their situation will be.
Yes, thanks.
So does that answer what you're asking?
Yes, thank you.
Okay. So there is something about shoes. Thank you, Kristen. The shoes, they should kind of have a smooth bottom versus a rubber bottom, because what ends up happening is the rubber soles get stuck to the floor, and now that also causes the person to get stuck. So they grip the floor really well, and when their feet grip the floor, then this can also set them up for falling or for injuries, which is what we don't want to do. There are special tools, special cookware, special utensils that they can also use to help with cooking and making cooking a lot easier. So they do have special utensils and cookware for Parkinson's folks. So that is true. So I do appreciate that about the shoes, because I did forget about the shoes. All right, so did you guys want to do a Zoom session this Saturday from 10 to 12? I wanted to ask that before I left. All right, so I will send you that link. We'll see you at 10. And then we'll start looking at grief and SIDS. We'll start looking at that. And then I'll get better clarification. I'll go back to Lippincott and check. In the United States, viral is more prone to, viral meningitis is more common, but I just want to make sure that I'm not saying the wrong thing. But I do know that viral is more common in the US. If they're looking at it globally, then, we'll see where the numbers are. Make sense? All right, see you guys on Saturday. Oh, yes, Fontana.
Ms. Hudson, I just have a question regarding the clinical.
Okay. Can we dialogue about that at a offline here? It's
just about the concept map use.
Oh, the concept map.
It's like a general question. So can we use any concept map in the community, under community for the weekly concept that we do, or we have to choose the one that we have lecture on that week?
So what you should be doing is using the concept for what you're studying for the week. So the guide that you did, the concept would be grief.